past Thanksgiving, and we are pretty much barreling right towards Christmas. So if you haven't done your Christmas shopping yet, make sure you do that. But that's not what you're here for. You are here to hear some more ASMR anatomy. And today we are going to dig in a little bit more to we've been hanging out in the spine and the vertebrae here for the last couple videos, and now we're going to be moving now from what it is. You know, we've been looking at, obviously you can see the individual vertebrae, the form and the shapes of the different vertebra classes as you move down the spine. But now we're going to kind of get into some of what supports those vertebrae, how they work together functionally, and just the components around it, because, you know, if we were just a bag of bones, that'd be no good. There's obviously a lot more involved that allows us to move, feel, you know, everything that goes with that. So, really, without further ado, let's dive in, shall we? Starting out here, we are going to be talking about the intervertebral discs. So, as it says, inter, think between, and then the vertebral discs. So these are discs that lie between the different vertebrae, this little kind of squishy section right here. So it says intervertebral discs in the vertebral column, the mid-sagittal section of T11 and T12 left lateral view. So we've got T11 and T12. We've chopped them in half and we're looking inside here. The intervertebral discs occupy the spaces between the vertebrae, intervertebral joints. Okay, so that's what we got here. We've got your vertebral canal, which we kind of talked about in the last video. And really what we're doing here by looking at this picture and these different features is we're orienting ourselves. And what it means when you orient yourself is that you figure out, all right, where am I at? What am I looking at? And where am I looking at it from? So you've got your superior articular facet up here. Your vertebral arch is hanging out in here. Your spinous processes here, they're also cut in half. And then your ligamentum flavum, we'll get into the spinal ligaments here soon. And then the interspinous ligament. So two distinct ligaments in here that are serving functional purposes between the spinous processes and the vertebrae. And then the annulus fibrosus and the nucleus pulposus. So nucleus, you can usually think on the inside, just like there's a nucleus inside the cell. There's an inner component of this intervertebral disc, and then an outer component. And anytime you've heard of like a herniated disc and things like that, it's this annulus fibrosus that usually kind of leaches out whenever there's instances like that. These are all both the components of the intervertebral disc. So it's not just one contiguous substance in here. There's multiple components. Alright, so the structure of the intervertebral disc, we looked at it from a side view, and now we are going to look at it from an anterior view, and we've got it chopped in half. So here's your nucleus pulposus right here, which we saw here, just from a different angle. And then your annulus fibrosus, kind of a surrounding ring around it. And then the hyaline cartilage in plate is just giving us something. This hyaline cartilage is another supportive layer, just like cartilage is in your knees. We have it here as well. Your transverse processes, your superior articular process, and then hanging out back here that we can't see would be your spinous process. Got a new feature here, the marginal ridge, or the epiphyseal ring. The body of the vertebrae and the intervertebral surface itself, which lies just beneath your hyaline cartilage. So we have an anterior superior view, so looking at to the front from the front, and then a little bit from the top, with an anterior half of the disc and the right half of the end plate removed. The intervertebral disc consists of an external fibrous ring, the annulus fibrosus, and a gelatinous core, the nucleus pulposus. I actually misspoke earlier. The annulus fibrosus is not the part that leaches out if you have a herniated disc. It's actually this nucleus pulposus that can kind of slip out through the annulus fibrosus. Forgive me. Figure 218 here, the relation of the intervertebral disc to the vertebral So this is an anterior view looking at it from the front of L3, L4. So pretty sizable vertebral bodies here because of the lumbar. And then another look at that marginal ridge or epiphyseal ring, as you can see. And then the crossing of fiber systems of the annulus fibrosus. So kind of like you could think of it as a very thickly woven fabric. You've got multiple different layers here that make it very durable, because if you're anything like me, you have definitely put your spine to the test through athletics, or working out, or lifting with your back when you should have lifted with your legs, as the saying goes. Lift with your legs, not your back. So this is obviously coming through in the clutch, because we are oftentimes acting a fool and putting that to the test. All right, let's get pumped. Another clinical box. Clinical box 2.4. A disc herniation of the lumbar spine. I think we're about to talk about the nucleus pulposus part in it. Guys, if I'm ever wrong about something, feel free to leave a comment and let me know. I am not impervious to, or I'm not perfect in my pursuit of knowledge. So I would just as soon get something right, and if I ever misspeak, feel free to let me know. Let's clear it up. Let's have the right information be out there. I am not the resident authority on these things. I'm just doing my best to share something that I think is interesting with you all. Now, disc herniation in the lumbar spine. As the stress resistance of the annulus fibrosus declines with age, the tissue of the nucleus pulposus may protrude through the weak spots under loading. Okay, I was right. How about that? If the fibrous ring of the annulus ruptures completely, the herniated material may compress the contents of the internal intervertebral foramen, or the nerve roots and blood vessels. You can see the posterior lateral herniation below. These patients often suffer from severe local back pain. Pain is also felt in the associated dermatome, which we'll see in figure or on page 42, at a much later point in time. When the motor part of the spinal nerve is affected, the muscles served by that spinal nerve will show weakening. It is an important diagnostic step to test the muscles innervated by a nerve from a certain spinal segment, as well as the sensitivity in the specific dermatome. An example being the first sacral nerve root innervates the gastrocnemius and soleus muscles. Those are muscles of your calf. Thus, standing or walking on your toes can be affected. So, let's get into this a little bit. We've got a radiographic image here, and fat in the epidural space is indicated here, and then here is a herniated disc. So, let's compare here. Normal, normal, and then we've got a pretty clear herniation, kind of where the nucleus pulposus is leaching out into the spinal cord area here, so that's obviously very problematic. And then there's a feature here called the cauda equina in the CSF. So what you've got here is you've got the spinal canal, and then you've got your spinal cord running through here, and then it highlights the cauda equina. So for those of you who aren't brushing up on your Latin a whole lot, cauda equina, I think equine sports, things like that, horse, and cauda is going to be the tail, so it's the horse's tail. So the reason it's called this is because this is the part where the spinal cord comes to a cone, and then all these nerve roots just fire out and spread out into what looks like a horse's tail, and those are the nerves that innervate all of your legs. So this is why you can see different symptomology in the legs and things like that in this example, talking about the gastrocnemius and the soleus muscles. So the cauda equina is right here, and it's surrounded by CSF, which is kind of a liquid buffer. And anytime you've got anything intruding or impinging on that, that's no good. And then here's your sacrum down here just for orientation's purposes. Here's another look at the disc itself. Really, again, kind of they give you different looks from different vertebrae. So this looks to be more of this looks like a sacral vertebrae, I think. Because the sacral canal looks really narrow there, and then that looks like the cauda equina. You can kind of see all the different little individual nerves. And then it says there's a dural sleeve with a spinal nerve. And then there's a posterior herniation. Forgive me. It's showing us a herniation. So there's the nucleus pulposus breaching the radiographic finding. So, in the MRI, a conspicuously herniated disc at the level of L3, L4 protrudes posteriorly, transligamentous herniation. The dural sac is deeply indented at that level. And then CSF just stands for cerebrospinal fluid. And that, again, that's kind of your liquid buffer around your spinal cord. And then we've got something a little bit different here. We don't have radiographic imaging, but this is going to be a posterior lateral herniation. So posterior at the back, lateral to the side. And what is it? What we see right here, nucleus pulposus, back and to the side, posterior lateral. So we got spinal dura mater. That's part of the covering of the spinal cord, or excuse me, of the spinal canal. And then the spondylolymphocyte. I don't know why, or excuse me, spondylophyte, excuse me, misspoke. The herniation itself, the nucleus pulposus, and then the dural sleeve with the spinal nerve right here. So the spinal nerve is coming off of that cauda equina, coming out into the different canals. A posterior lateral herniation may compress the spinal nerve as it passes through the intervertebral foramen. If more medially positioned, the herniation may spare the nerve at that level, but it impacts nerves at inferior levels. So let's look at this picture here. So your dural sac, dural sleeve, your compressed nerve roots. So basically what it's saying here, there's not a fantastic picture to show it, but we've got a posterior view of the vertebral arches. We can work with this picture. So the posterior lateral herniation, you can see, is going to very much impact the spinal nerve roots. And what I was saying is that if it's more medial, it can impact the level below it by coming straight back and just pushing this whole canal backwards. So either way, it's no good, but a lot of times the testing that they can do can either confirm the findings or give greater insight on what they should look for on the radiographic findings. The idea is that these two things should be working together to create a better picture, no pun intended, of what's going on with the patient. Alright, so now we get to go into the joints of the vertebral column, and this says it's an overview. So we got table 2.2 over here. We've got the cranial vertebral joints. So the atlanto-occipital joint. So the occiput, or the occipitus, is the very bottom of the skull. And then, as you remember, the atlas is right here. So perfectly named. It's going to be the occiput with C1, where those two come together. A lot of these are named pretty intuitively. It's just the legwork is learning the features of the anatomy itself. So once you know that, you can step one is to learn it. So if you don't learn it the first time, it's going to keep coming back to you. So learn it the first time, and it becomes a lot easier as you build out from there. You've got your atlantoaxial joint, again, perfectly named, because you've got your atlas joining with your axis, C1, C2 here. So this is the top of C1, and this is C1, C2. And then your uncovertebral joints that are C3 through C7, because those are all going to be the same. And then you have your intervertebral joints, which is going to be present from C2 through S1. And then the joints of the vertebral arch, that's going to be the zygophyseal joints, and that's also from C2 to S1. So the zygophyseal intervertebral facet joints, the orientation of the zygophyseal joints differs from the spinal regions, influencing the degree and direction of the movement. So joints, perfect 45-degree angle. And that goes along with those bones kind of interlocking together. And then we see these gaps. They're very intentional about these gaps because that's where your intervertebral discs that we just covered are going to be hanging out at. So this is thoracic region, left lateral view. The joints lie in the coronal plane, like so. A little bit more on the uncovertebral joints, anterior view. And that's going to be C3 through C7. The uncovertebral joints form during childhood between the unicate processes of C through C7 and the vertebral bodies immediately superior. The joints may result from fissures in the cartilage of the discs that assume their articular character. If the fissures become complete tears, the risk of nucleus pulposus herniations is increased. And that was shown back on page 15 that we looked at. So the dens, the very prominent feature on C2, the prominent feature of axis on C2. The lateral atlantoaxial joint, the unicate processes, all the way through the C7, posterior tubercles and anterior tubercles, both parts of the transverse processes. And again, tubercle, think kind of a protrusion or something sticking out. And then the groove for the spinal nerves. So what lies behind here and is protected by the intervertebral arch is the spinal cord going through here. And then the spinal cord shoots off those nerve roots through here. And those are what are heavily impacted, especially by a posterior lateral disc herniation. So uncovertebral joints in the cervical spine of an 18-year-old man, anterior view. An uncovertebral joint enlarged, anterior view of the coronal section. So they give us the gift of all these different perspectives and looks, so that if you didn't see it the first time or you didn't quite get it, sometimes a different view or a different segment can maybe make it click in a way that it didn't before. Alright, clinical box 2.5. Nice. Let's get pumped. Proximity of the spinal nerve and vertebral artery to the unicate process. The spinal nerve and vertebral artery pass through the intervertebral and transverse foramina, respectively. Bony outgrowths or osteophytes on the unicate processes resulting from the uncovertebral arthrosis or degeneration may compress both the nerve and the artery and can lead to chronic pain in the cervical region. So all through here, very, very important innervation and vasculature running through there. So if there's any bone issues with the transverse process or with the intervertebral portions, that's no good. So again, this is cervical spine. You can tell by the triangular shape that we talked about last time, and the spinal nerves are coming out, and then the vertebral arteries right here. So here we're looking at anteriorly, here we're looking at it superiorly, and this is C4. It says fourth cervical vertebrae, posterior root ganglion. So yeah, this is a major highway running through your neck right here. Joints of the vertebral column, the craniovertebral region. So occipital condyle. So this whole region right here at the back and the bottom is your occiput. Superior nuchal line, external occipital protuberance. You can probably feel that if you put your hand on your back of your head right now. You can probably feel this. The mastoid process of the which is a part of the temporal bone. The styloid process, think stylus, looks just like it, of the temporal bone. The dens of the axis, that very distinctive feature. The atlas and the axis. So again, that dens poking right up in there. And that atlanto-occipital joint was talking about is the juncture between that occiput and the atlas right here. Just a different look at it. The median atlanto-axial joint, so the middle of it. The superior articular facet, the lateral mass of the atlas. Again, the dens, it's such a unique thing that anytime you can identify it, you're pretty much immediately oriented. Ligaments of the craniovertebral joints. So a test or anything here, so you don't have to memorize them, but we're going to run through them relatively quick. You've got the alar ligaments. Here's the anterior tubercle. So this is the front, and here's the back. Let's orient ourselves. Transverse ligament of the atlas. Here's the dens. The vertebral foramen where the spinal cord's going to run through. The posterior tubercle of the atlas. Lateral mass of the atlas. Your transverse process, of course. Another look at the alar ligaments. Longitudinal fascicles. We'll get into that later. The apical ligament of the dens, so that helps hold the dens in place. The tectorial membrane. That sounds important, doesn't it? Transverse ligament of the atlas. Transverse processes. Intertransverse ligament. So those still have to hold in place. They can't just kind of flop around all over the place, the transverse processes. Posterior arch of the atlas. The nuchal ligament. The posterior atlanto-occipital membrane. And the groove for the vertebral artery, which we saw on the previous page. And then here's the capsule of the lateral atlanto-occipital joint. A lot happening in a very, very small area. Dissection of the craniovertebral joint ligaments. Or let's read this little point up here. The atlanto-occipital joints are the two articulations between the convex occipital condyles of the occipital bone and the slightly concave superior articular facets of the atlas. The atlantoaxial joints are the two lateral and one medial articulations between the atlas C1 and the axis C2. So there's that styloid process again. External occipital protuberance, again, that feature that you can feel. And then the posterior atlanto-occipital membrane here. The lateral atlantoaxial joint capsule. And the ligamentum flavum. We'll get more into that later. I'm sure we'll highlight that. Let's see. The nuchal ligament is again over here. Another look at the tectorial membrane, or posterior longitudinal ligament. And then the vertebral arch, the atlanto-occipital joint. Another look at the alar ligaments. It says that highlights that the cruciform ligament of the atlas is removed. Otherwise, we wouldn't be able to see this current view. Every so often, they'll kind of show that something's been cut in half, but this has just been removed so that we can have the view that we want. The tectorial membrane, the posterior atlanto-occipital membrane, and the vertebral arches. Let's see. Not necessarily anything different going on here than what we've already shown and seen and talked about. It does say that the transverse ligament of the atlas has been removed. So what was once here has been taken out of the way so that we can get a little bit of a closer look. Let's see. How much further do we want to go, guys? I think we can go a little bit longer. The vertebral ligaments overview and cervical spine. The ligaments of the spinal column bind the vertebrae and enable the spine to withstand high mechanical loads and shearing stresses. When you hear shearing stresses, think like the potential to tear, to really, really hurt, and limit the range of motion. The ligaments are subdivided into vertebral body ligaments and vertebral arch ligaments. So, vertebral body ligaments, the anterior longitudinal ligament that's along the interior surface of the vertebral body, and the posterior longitudinal ligaments along the posterior surface of the vertebral body. Again, pretty intuitively named. Vertebral arch ligaments, ligamentum flavum, is between the laminae. The interspinous ligament is between spinous processes. Supraspinous ligament along the posterior ridge of the spinous processes. And the intertransverse ligament is between transverse processes. The nuchal ligament is between the external occipital protuberance and the spinous process of C7. Corresponds to a supraspinous ligament that is broadened superiorly. Now I could be remembering incorrectly, but I do believe that the nuchal ligament is one of the main ligaments that exists, and it's between the beginning, the base of your head, and to that external occipital external, what was it called? God, my goodness. At C7, right here, the vertebra prominence. Yeah. That palpable point at C7. So this nuchal ligament exists to prevent the hyperextension that we saw on the diagnostic case on the X-ray a few pages back in the previous video. So pretty interesting. That's the kind of the fail-safe that exists. So the anterior longitudinal ligament is here up here. So this is again anterior. Automatically tells us this is the front and this is the back. Transverse process is here. The intertransverse ligament is here. The supraspinous ligament is here, and that just runs along, connecting spinous process to spinous process to spinous process. Posterior longitudinal ligament. You've got a pedicle of the vertebrae here, the lamina of the vertebrae here. So it's kind of showing the relationship there that exists between all of the bony prominent portions and then all the ligaments that just run between, holding these vertebrae together and establishing the relationship functionally. And again, just as a reminder, the pedicle and the lamina make up the vertebral arch. So when you hear vertebral arch, you can just think, oh yeah, that's those two components put together. The inferior articular process is right here. The superior articular process is right here. And then that ligamentum flavum, just a fun one to say. And then the intraspinous ligament here. Anterior longitudinal ligament is the anterior view with the base of the skull removed. So really, what you can know about the anterior longitudinal ligament and the posterior longitudinal ligament is that these ligaments run the full length of the spine on the front and the full length of the spine on the back. And so it runs just in front of the spinal cord, which is going to be hanging out right in this little space right here. Internal occipital protuberance. We'd seen the external one previously. Here's the occipital bone down here. The basilar part, think base. Atlanto-occipital membrane here. Transverse process. There's the atlas, so C1, C2. Anterior longitudinal ligament is tucked away inside of here. And again, this picture is kind of the culmination of everything we've been building towards over the last few pages. Intervertebral disc here, and the vertebra prominence at C7. And so that means that on the very back here, you're also going to have that nuchal ligament that we talked about from the occipital protuberance down to the vertebra prominence. Oh, still going to talk about here, or the posterior longitudinal ligament here. Posterior view of the vertebral canal opened via laminectomy, so the laminae have been taken off here. And the spinal cord removed. The tectorial membrane is a broadened expansion of the posterior longitudinal ligament. I think we will go just a little bit longer here, and then we'll stop at the muscles of the back. You got some sinus action here, the sphenoid sinus, so we're getting close to, here's, as you can see, teeth, so we're getting pretty far up. The occipital bone, the anterior atlanto-occipital protuberance, the anterior arch of the atlas, and the maxillary bone is right here, and that's the base of your teeth on the upper portion of your mouth. The hypoglossal canal. So we'll talk about the hypoglossal nerve later. All the different the 12 cranial nerves. The apical ligament of the dens up here. Tectorial membrane. External occipital protuberance. The dens. There's that dens again. Transverse ligament of the atlas. The posterior atlanto-occipital membrane. The nuchal ligament. So you can finally see it here. And again, from the occiput down to the vertebra prominence. Ligamenta flava, vertebral arch, intervertebral foramen, spinous process. You know, all these things that we've already covered, just from a different view. And then we've got another radiographic image. This is a mid-sagittal T2 weighted MRI left lateral view. Now, my interpretation of the weighted MRI portion, that should mean that this patient was upright, not laying So basically, this radiographic imaging is a reflection of this picture. It's always nice to be able to tell what it is that you're looking at. I mean, these drawings make it very neat, but if you've ever had the opportunity to do a cadaver study, whether that be on a person who's passed away or on an animal or anything like that, what you see compared to this picture, like these pictures do us a great service, and then you get into it and you're like, what am I looking at? So it's always helpful to have these drawings so that you're at least, and that's why orienting yourself is so important, because when you actually get into it, you're like, where am I? Vertebral ligaments of the thoracolumbar spine. So thoracolumbar means it's the juncture of the thoracic and lumbar vertebrae. Again, everything that we've kind of already covered, but just a different section and kind of zoomed in. So your intervertebral disc, your anterior longitudinal ligament running the length of the front, your posterior longitudinal ligament running the length of the back here. Spinal cord's going to run through here, vertebral canal. And then your transverse processes on the side of the vertebral body, the psychophyseal joint capsule. Supraspinous ligament. That's the ligament running over the spinous processes, supra above the spinous processes. And then one last page, and we'll call it a day here. The anterior longitudinal ligament running the length of the front here. The ligament flava and the intertransverse ligaments. Anterior view of the open vertebral canal at the level of L2 through L5. What's been removed? The vertebral bodies. So the bulk of, so this is an anterior view looking at the front with these bodies removed. So you're really just looking at the spinal canal and then the backside of the vertebrae here. That's what we're looking at. So we've got a pretty clear view of the intertransverse ligaments, the transverse processes. That posterior longitudinal ligament is also cut away because it hangs out on the back of the vertebral body. And then the anterior longitudinal ligament, superior articular processes, ligamentum flava. And then, the posterior longitudinal ligament removed are the vertebral arches at the pedicular level. So this is just a look at the back with the portion cut away. The nutrient foramina. We haven't talked about that yet. I don't know if it's going to be wholly relevant to what we're trying to talk about. It's just a little feature that they decided to highlight. Yeah, everything we've already covered to this point. So let's see where we're going to pick up next time. The muscles of the back. Oh yeah, this is going to be good. I'm excited. I usually try to stick to a 2-video a week if possible recording schedule. That may be a little bit challenging. My family, we're actually moving into a new house, so we're very excited about that. Because of that may present some logistical challenges to get 2 videos out, but as soon as possible I'll try to get back to recording that schedule, and whenever we do, we'll get into some more Bible reading, and when we go back to the anatomy series, we'll be picking up in the muscles of the back. So thank you all for taking the time to watch. I know you could be watching or doing anything. There are a lot of people that make good content out there, and yet here you are spending some time with me. I don't take it for granted. If you have anything you'd like to see, feel free to leave a comment. If you have any constructive criticism, I know I'm not perfect, and if you like something that you see, please subscribe, and I would love to bring you more content like this. But with that being said, have a great rest of your day, and we'll see you soon.